Thank you, everyone, for joining us for another Learning Lunch hosted by Format Approved. My name is Brian Johnson. I'm the Senior Director of Online Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch title is What is Working for ACOs Today? We're joined today by Lou Galterio, the President and Founder of the Suncoast Rio. Lou has a wealth of experience serving as the CIO of different hospitals. He's deeply involved with electronic quality measurement and interoperability standards. You couldn't ask for a better expert to address the current state of ACOs, which draw tremendous interest across the industry, but that remain mysterious and even a little forbidding for many folks. And I would even put myself in that group a little bit. A lot of interest in ACOs, but a lot of questions too. And Lou, first of all, thank you for joining us so much. It's a pleasure to have you with us.
Oh, thank you for having me.
Now, before we go on, I do think it's worth taking just a moment if you could explain to us what the Suncoast Rio does, because I don't think I can do it justice, but it is relevant to our topic.
Yes, thank you. The term RIO stands for Regional Health Information Organization, and we've evolved over time. Primarily what we're doing now, where the value added boils down to, is in our ability to electronically transmit PHI data, protected health information data, either to government, where we have standardized, certified products that will transmit electronic information to the government, to payers, between providers. We're a registry, a PQRS registry. We do a lot of that, and we're helping a lot of hospitals now achieve meaningful use too. So in a nutshell, that's what we do.
Yeah, I was going to say, obviously, all of this is, integral to successfully running an ACO. The quality reporting is so important for all of that. So I'm sure we're going to touch on these topics throughout our presentation today. Before we continue to the main part of our session, I just want to let our audience look at the questions we're going to address today. You can read those over to get kind of a roadmap of where we're headed, and then let you know some quick housekeeping notes for how we're going to do our session today. Remember that you can ask questions of our presenter at any time during today's session by entering them into the chat area. We're going to hold those questions for the end of our session, but when we get to the end, we'll address as many questions as time allows. If we do run out of time, we'll pass those questions on to our presenter, and he'll be happy to follow up in writing to any of the questions we don't get to. Note as well that we are recording this session, and we always send a follow-up after our Learning Lunch sessions to all registered attendees, whether they're able to make the live session or not. So you'll receive an email with links to both the slides and the recorded version of the event. So we always get questions about getting the slides, especially for an interesting topic such as the one we have today. Don't worry, we will send those out after our session. All right, well, let's get to it then. Lou, let's talk a little bit about history here. Where did ACOs come from, and where are they going now?
Okay, well, to understand where accountable care organizations came from, it's a very rich background that one would have to look at and pretty much go back to the days of reporting quality that hospital quality assurance departments have done for many years. So the short answer to where did ACOs come from was a part of CMS created, I'd say, right around the time of the meaningful use creation of EHRs, as well as when the ONC itself was created. There was an idea called an innovation center, a CMS innovation center. And that organization came out with a number of different ideas that they tried to see, whether they worked. And the Accountable Care Organization was one. Actually, the first step of the Accountable Care Organization was really a shared savings initiative. And just real quickly, with a shared savings, the idea was that if a provider group with a certain number of beneficiaries could look at a number of services that they could say bundle. You'll hear the term bundle services. Could look at a number of services and provide them to a specific group at a lower cost than if they were individual, then there would be a sharing of the savings and also a sharing of the margin, the profit on top. So without spending too much time on history, because I know history lessons sometimes can be a little boring, but the hospitals have been doing quality reporting for a long time. They either reported to the Joint Commission, JCAHO, or to CMS, or they would report HEDIS measures or Medicare Advantage plans. So all these different reporting approaches were done many years by hospitals. And again, so just to end on this slide, it's a very important point here is, and you'll see this on the next slide, is the idea was to make sure providers can provide care with an income that they could depend somewhat on, but at the same time be able to innovate and do more and get rewarded for it. So I think when we talk about the next slide, which I think speaks about the difference between this and HMOs, I could elaborate more on that.
All right, well, let's go to that one then. Well, I don't know if we're on the HMO slide yet. I know that's coming up. But this is certainly what you're addressing with the secure income. So let's look at this side of it. How do the commercial payers then play into the ACO structure?
Yes. Well, the ACOs, the Accountable Care Organizations, I think that term was coined way back by CMS. But it was if you talk to some people, they'll say it's a bad idea, and you talk to others, they'll say it was a good idea. How the commercial payers play into this is you could start seeing they're doing ACO-like things. If you think of an ACO as really a contractual approach to two parties, one party being the providers of care and the other parties being those that will fund that care. So for most cases, that would be a payer. So I've heard it said that if you want to know how many types of ACOs there are, there's as many as there are contracts out there. So you think of it as a contract. That is the main message to this slide, is it could be any payer source, and you have to measure what you're going to deliver. So as you being a provider are shooting for a win-win here. You're shooting to achieve the triple aim, which will, so there it is right there, better health care at a lower cost, and you're looking to improve the experience of care, the health of populations, and the cost of health care per person. So that's the triple aim. So providers can give better costs, and payers could pay less for that cost if there's agreement on how to achieve that triple aim. So think of it as a contract, and you'll see that on one of the upcoming slides, is the patient-centered medical home is actually a type of an ACO, an Accountable Care Organization.
All right, well, here we are talking about HMOs then. So here's kind of a snarky way of putting it, but I think it's a valid point, or something that people are thinking out there. Couldn't you just say that an ACO is just another kind of buzzwordy way of a name for a low-paying HMO plan?
Mm-hmm. Yeah, that was very often in the early days what was being feared and what many providers didn't want to get involved in. If you go back to the history of a health maintenance organization before they started evolving to the more successful, say, Medicare Advantage plans, but in the old, and I'm sure that what I just said is going to get some people saying, well, we don't agree with that, if they're more successful or not. But the original idea of a health maintenance organization, HMO, was that you would have a fixed rate per beneficiary, per capita, that would go to physicians, and there would be a gatekeeper that would send patients to different specialists. The idea was to save care on specialty care. I'm sorry, my screen just blanked out. It'll come back in a minute. So there it is. Okay, my screen just blanked out and came back. So that was the old HMO concept. Now, what people found was that as the ACOs concept came out, the fear is that if you're just going to pay providers on a per capita basis, you're going to lose the incentive of being innovative and the incentive of being driven to do something above and beyond, you know, what everybody else, every other provider. You could look at it and say, as a provider, well, what's in it for me to do extra if we're all getting the same amount of money? So the idea of an ACO was to sort of balance that, to say, we're going to give you the per beneficiary per month, per capita payment, but at the same time, we're going to work in a way contractually that if you achieve a certain savings above what, you know, that we contracted to in the beginning, we'll share the extra with you. So let's say I go to a doctor or I'm a patient and I break my leg and I normally have to go, maybe I go to an emergency room, then I might go to an inpatient facility, and then maybe I might go to an ambulatory, a follow-up. When you add up all those codes together, the idea with an ACO is let's bundle them and see if we could do the same care for common things at one price. So there's a lot of things here that I would like to talk about. You have to be able to do what I just said, you have to be able to measure what you're doing. And you're going to see as time goes on that the granularity of measurement is becoming more and more granular. So that's the ICD-10, as you know, is much more granular. I think 6 times more codes than ICD-9. So metrics are very important because one has to measure what it is they're doing and if they're being successful. If you have the minimum, the old ACO shared CMS minimum of 5,000 beneficiaries, you have to be able to follow them throughout the system of where they're going. Are they, you know, as I said, if you have different settings of care, how do you follow that continuum? How do you follow that transition? And then not only measure them by having the measures and the metrics, but then how do you look at those and determine how am I going to look at statistically what I've got here and how I could do it better and help more people. And you'll hear about risk stratification, the idea of how do I find that best patient to assign to the doctors so that everybody wins not only financially but with health care. Very important point there toward the bottom is the technology and security is going to, you know, when you've got many provider practices who normally worked alone and now coming together, you're going to see a order of magnitude maybe of more potential of security and compliance possibly being compromised in technology. So you have to really use technology in a good, knowing way. And again, back to the HMO question at the beginning, a patient-centered medical home. I've seen some payers like United or Optum rather, and Aetna. You could see many stories out there where the providers receive much more than the 2.5% that CMS talks about. You could see up to 15, and I've seen even higher on that.
So if you get this right, you can make considerably more money than you would otherwise. Is that
that's
what you're saying here?
That's what I'm saying.
Okay. All right. Well, let's go to our next slide then. You mentioned some of the difficulties around compliance, that if you're integrating all these different providers together, there's more complexity there and more potential for trouble. So let's talk a little bit about the HIPAA and EHR audit, and then there's also the antitrust and START considerations. Tell us more about those concerns.
Yes. Well, there are many rules on the books that try to discourage providers from sending patients to only their own, other providers that there might be a financial interest with. So that's where the Stark laws come from, and the fear that there's been studies, many studies that have, well, not many, but there's been a good number of studies that have shown that in any type of organizational setting, and that includes providers, as you have more and more of, we'll say providers now, but I don't want anybody on the call to think that I'm saying this only happens to providers. But any people who get into an organized situation will start to tend toward potentially controlling the market. So so this is why the antitrust rules came about. There was the recognition of a tendency toward monopoly, just in general, and so there was a fear that healthcare would fall into this antitrust. That more and more hospitals, and it's been proven or shown that as more and more hospitals get together, the prices of services to the beneficiaries, to the patients, in many cases go up instead of down in a negotiation with the payers, because there's more of a chance to negotiate. There's a stronger bargaining position. So what the government, when they worked out the first CMS ACO concept, was the idea that there would be a safe harbor. And that means that if you apply to CMS to be an ACO, because you have to apply, if you decide to be a CMS ACO, you have to apply to the shared savings program and have a good organization in place and address a number of questions. And then once you're granted that, they tell you what measures you're going to use. They're shared savings measures. They're much like PQRS G-Pro measures, and you get a safe harbor. So no one could say, well, because there's 4 providers in the same ACO, therefore they're a monopoly. There is a safe harbor. There's an exception for that. So that's the safety on that. And so we talk about a number of things on that slide heading of, if you're going to have electronic health records, they have to be certified. If you're going to be reporting quality to them, through them, of course, my organization reports quality. We're a PQRS registry as well as a hospital inpatient. We get audited when we submit quality measures on behalf of providers. We're saying that these things are right and we're as liable to them. So, audit is something. You be very aware of the compliance rules and the consent rules.
So how does it then work in terms of the bundled payments and value-based purchasing and the shared savings? How does that all fit into the ACO picture?
Mm-hmm. Well, some of the things here I've talked about already. And I think how does it all fit in? The value-based purchasing is coming. And again, we go back to the first slide where I talked about hospitals have been doing this for years. The idea that the hospital or the provider, and it's filtering into the whole idea of ACOs is, of course, the ambulatory world, but hospitals can be part of them, and there are many hospitals that lead them as well. But the value-based purchasing, of course, is the idea of reporting the quality measures in certain cohorts that will determine, if you look at a pie chart in your mind and think of it in quadrants, say 3 or 4 quadrants, a percentage of those, maybe 15%, will be patient satisfaction. Those are, if you're a hospital, that's the HCAHPS. And if you're a ambulatory provider, they're starting now to take CCAHPS, Consumer Satisfaction Survey. Then there are the certified, the electronic clinical quality measures. Now, if you go and see, well, how many of those are there, there's at least 700 of them. And all of those 700 that are held by the National Quality Forum, that's the NQF. That's a public-private organization that is given the approval by the government and other organizations to endorse measures. So in other words, if someone walks in and says, if you walk into a hospital and you're presenting with chest pain, there is a measure that says, were you offered an aspirin within a certain number of times? And they're much more complicated than that, but there are over 700 of these, and then when you look at all the different ways to slice them and dice them, you can see it's a Rubik's Cube of you find providers looking for the best grouping to achieve the clinical and the financial goals they can. So that's why I said earlier, you may choose, my screen just went blank again, you may choose a joint commission set of measures or a HEDIS set of measures. I'm sorry, my screen keeps going blank, and I think all I'm seeing is a black screen.
Might be a screensaver. I wonder if
some kind of a timing thing.
Okay.
So ACOs are growing. The number of ACOs from year to year has been geometrically going up. This year, the growth is, as the rate of growth is sort of leveling out, but they're still going up, but not as geometrically as they were in the first couple of years.
Okay. So I think a lot of people may, think, maybe wishful thinking, but that if they've got their certified EHR and they've got it set up right, doesn't that basically just take care of the quality reporting for them?
Ultimately, if we're only talking about the technology tool, ultimately that's where that's where we're going to end up. However, right now there is more than just EHR, achieving EHR quality measures. So the EHR quality measures is a subset of all the other measures, the shared savings, as I mentioned before. If a doctor wants to not just get their meaningful use money, but also wants to, and avoid penalties, but also wants to report through a registry, there's more choices with PQRS, for example. So there's a number of, actually there's a new word coming in called merit. I think it's called merit-based measures. I might be off on that a little bit. I think I mentioned it coming up in some of the slides coming up, where the goal of the government and the commercial payers is let's bring all these different ways of reporting quality together. So if you were to go and look at some of the portals that I have to use in my organization, we have the ambulatory PQRS, then we have the hospital inpatient, hospital outpatient, then we have a way for doing it for end-stage renal disease, then we have another way doing it if you have an electronic health record, and then you have this, these newest type that came out is which I'll talk about in a minute, is the certified clinical quality registries, and that's starting to go across payers and bring in the patient satisfaction. So, just having an EHR, I guess in 5 to 10 years might be enough, because everybody's going to EHR being the core of everything. But what if you're a doctor and you don't even have an electronic record? What if you are one of the specialties who didn't get meaningful use money by having a certified EHR, but you still have an EHR? How do you, that doesn't mean you shouldn't be able to get your incentive or avoid penalties. So quality is here to stay, and organizing, there's more, and if you're looking at it contractually, an organization has more pull as an organization than people alone working with payers. Understand, I'm writing there the statistics, understand that your statistics are, make sure that you know where they're coming from. There's a lot of analytic programs out there that just report statistics. How do you know that data is real? How can you depend on it? If you get audited, can you stand by it? And even if you get audited by your payer, make sure that you're reporting correctly.
So you've talked about the need to integrate various, stakeholders and all of that. How do things like the transitions of care and population health and then secure health information exchange, how do those all come together in an ACO?
Well, I think the organizations, if you looked at the CMS ACO, you would see that it's at least 5,000 beneficiaries need to be in it. For example, you need to have, it has to be, doctors have to be running it, at least the original method, and you have to be able to securely exchange information among all your players. So I would say, how else can you do that if everyone's using a different system? I mean, this is why ONC, pretty much was created, was to make sure that there was a standardized way across all continuums so that the patient data can be trusted. So an ACO needs to, I feel strongly, needs to use standard-based software. Messaging, is very important. Right now there's a number, not too many, but there's a number of ways to do secure messaging. But of course, the one that's becoming the biggest is known as direct. And I shouldn't make it. That was a statement that may not be 100%, but direct is a biggie. The ability to send an encrypted message from one provider to another. One way to do it is with called a direct protocol. Another way to do that, if you're looking at government open source standards, is the protocols, the systems known as Connect. And I mean, we go back to the days of the National Health Information Network, which today, by the way, is called the eHealth Exchange. And being part of that, there's quite a number of players on. If you want to see some of the people involved in this, you go to the company that's running it now. It's a nonprofit. It's called helpewayinc.org. Helpeway, H-E-A-L-T-H-E way, W-A-Y, inc.org. And if you want to look at the players in the direct who are working together to get direct, everyone using the same direct system, you could look at directtrust.org. So what's happening very soon with the Meaningful Use 2 is people are, if you're an ACO, you're going to have to send these continuity of care documents, and they're, everyone says, well, it's HL7, so it's okay. Well, it's not just okay. There's flavors of HL7, so that's why I use the word absorb, being able to absorb a CCD as well. Now, there's one more point I want to bring here, is the consent, compliance, and quality assurance. Our organization, and I think ACOs need to think about this, is there are, if you're dealing with patient consent now, you're sending patient data all over the place. You've got to make sure that and there's various forms that data could take, either in charts or PDF. Look at some of the work of the release of information companies that have already been out there. We just partnered with an ROI company that will make sure that when we report quality on behalf of an ACO or a provider group, that we're going to work together to make sure that all of that data is 100%, not only was consent given, but also 100% that we could say that this is valid and prove this is valid, that the notes and the measures match. So I think that is something that's going to be very important, is the compliance side of this.
So how can a provider then, isn't there a lot of risk then in trying to go down this road, given the cost of adopting the technology and finding the patient base? How can providers take on that risk?
Yeah, it's almost like a question. It's almost the answer to that question might be, how can you not look at some of the areas that ACOs are addressing today? So at the beginning, I was saying there's as many ACOs out there as contracts. Think of an ACO as a contract. There's going to be a point in the history of what our healthcare environment is going toward, where there's going to be a negotiation that's going to involve the provider of care. The patient will be very involved in the center. Patient-centered medical home has the patient in the center, and those who fund the care. So the high-level answer to that is, sooner or later, everyone's going to have to figure out a way to do an ACO-like structure. So going back to history of it, one could get an idea by looking at the pioneer ACOs that came out and looking at the cost structures. They spent millions to get the technology in place, to just understand that they were being compliant with all the requirements. I hope I got this wrong. There's a new organization out there called the National Association of ACOs. If you look at them, you'll probably see some of the bigger ACOs in there. Because we're starting to mature a bit in the space of shared savings ACOs and electronic, capabilities in care, then you're starting to see vendors start to spring up now. So the early day organizations of providers spent a lot of money to get this started because they were the first kids on the block. But now, there is a choice. There are some organizations that you can buy solutions from. So maybe looking up front when you're thinking of starting an ACO organization, look and see what vendors are out there already that maybe will do the whole thing for you. Or maybe you want to start it yourself and put together a project plan that says at these points, if we don't make these points of revenue, and if we don't have these patients getting this much better, for example, a population of diabetes patients, you're going to have a measure. What is there in general is the geographic area we looked at, is it more managed? So you're going to have different metrics you look at. Maybe you might want to say in your plan of becoming an ACO that you'll bring in a vendor somewhere in the middle for different parts of it. So you could have a hybrid approach. So that's where I say know the vendors and know what they're selling and how well do they understand the healthcare market. I won't say who, but I had a very large organization that wanted to work with us and just thought because they were large and around a long time that they could just step into this and everybody would be breaking their doors down. And it didn't. If a provider senses that a person doesn't know their business, or a COO or a CFO of a hospital, credibility goes out the door very quickly. And I'm writing there toward the bottom. Understand your counterparty. Now, I should have been more careful with that. Before I was in healthcare, which I entered in 1990, my background was in banking, so we talked about counterparties quite a bit. But it's just two sides of a negotiation is what I mean there. So if you're a provider looking at your payer and you want to have a contract negotiation, what is their hot buttons? They probably would, if you're a payer and you're listening to this, you probably would be more prone to want to suggest outcome measures, whereas a provider wants to be able to give their conception of better care, and they might want to choose process measures. So what is the middle ground there? There's something called attribution, where patients are attributed to certain providers. If you're a payer, you probably want that attribution to take place toward the middle or end or as the contract goes on, whereas if you're a provider, you want that all up front so that you have a pretty secure feeling that you're going to have income coming in and not enough beneficiaries. And I guess the last point there, and it goes back to transitions of care, and of course in my case electronic is important, know where your patients are going. When they leave your organization, where do they go next? And make sure that in knowing your referral patterns, that where they're going, that the organizations they go to are also have the technology so that the transitions of care can be addressed properly and noted, and you get credit for it, and there's audit trails that it happened. So
Well, before we go on, you said that, there's vendors offering total solutions. It's kind of hard for me to imagine what that looks like. Can you tell us more? How could a vendor offer a total solution when it comes to ACOs?
Yeah. We're still, by the way, my screen is blank again. I think it's a combination of me timing out and you at the same time. But let me answer that. Well, maybe it's just me here. I'm not. Well, I don't know if you're showing a new slide in front of you there, or if,
no, I think our audience can still see. At least that's what
oh, there we go.
The dashboard's telling me here.
Okay, good. Well, the slide I'm looking at now, I'm back into seeing a screen. It's the last thing is know your referral patterns. Did you change slides, or are we still on that?
No, not yet. No, I just was asking a follow-up.
Oh, okay. No, it's really organizations to do the soup to nuts offerings. They're growing now. My organization can do quite a bit of those. However, some of the larger ones, they'll focus on transitions of care, or they'll focus on population health, or they'll focus on analytics. So you've got these little pieces here and there. If you just want HIE, you'll see some of the bigger HIE vendors. If you look at, there's a study done by KLAS, K-L-A-S, where they actually looked at who are the ACO vendors, and I would venture to say that there's some that are pretty close, but it's still, the starting gate has just opened. So it's hard to find a soup to nuts vendor, but they are coming together. They're realizing that ACOs, that the original resistance to ACOs by many providers, that it was an HMO, is starting to melt away. Quality metrics are becoming so much more important. A lot of the providers that held out are now saying, okay, we'll do it. We'll have a contract. They may not call it an ACO. They may call it an electronic clinic. But so you need to find vendors that have solutions that you can pick and choose the ones you want, or have them do the whole thing. But now I don't want to go on record as saying that there are none out there. There are none out there soup to nuts that are big that I know of.
Okay.
Mm-hmm.
So is it really worth all the work then? Because, for a lot of providers out there, government incentives are kind of a small percentage of their overall revenue. And they may be thinking to themselves, well, it's just not worth the trouble for the small reward. So tell us more about why that's not the case. Okay.
Well, you're starting to see some changes go on in the CMS programs, where reporting quality, even though it's not a condition of participation, by the way, is CMS's term, and probably other organizations, for if you don't do these certain things, you won't get any Medicare reimbursement at all. It'll be zero. So you're starting to see, I would say, hints of that here and there. So quality assurance programs for a hospital reporting are required, but not quality reporting of electronic quality measures yet. But if you were to look at all the money and all the effort and all the time that's going on with CMS alone, and some of the payers like Optum and Aetna and all the big commercial payers, Blue Cross Blue Shield, they know something. So there's going to be a point where, unless you're a concierge doctor and are willing to not take any payer funding at all, you're going to be hard-pressed to find organizations that will work with you as a payer. So I think that's really important. The second bullet of merit-based incentive payment, I've heard that's going to be the new word that's going to be used to replace the PQRS, EHR reporting, QRDA. There's quite a bit of different systems, as I mentioned before. Claims reporting, as you probably know with PQRS, I believe it's been stated that this is the last year that a physician could go in themselves and use the QualityNet portal and report through claims. So claims reporting is going away. So if, little by little, all these things are being chipped away. I mentioned ICD-10. I mentioned earlier the qualified clinical data registries. And if anyone on the phone wants to look themselves, go to cms.gov/PQRS, and you will see all the different ways of reporting quality. And if someone wants to really be brave, go on to qualitynet.org, and that is, you'll see some of the different ways that you can report through CMS. I mentioned earlier the patient satisfaction is getting bigger and bigger. When you leave the doctor's office, you'll probably start noticing he's going to ask you, or he or she, or if you're in a hospital, this has been happening for years, did you get to speak to a nurse? Did you get to speak to a doctor? Did they communicate? Did you understand what they said? Those HCAPs are now CCAPs as well, and that's going to be important. And the last two bullets, if there's providers on the phone, there's going to be websites that are going to show measures that were achieved or not achieved that the public will see when they look at, so there's a hospital compare right now, CMS hospital compare. There's going to be physician compare, or it's already there. And also a special one of mine, a special one that I like, is they're starting to ask providers now how they feel about satisfaction. Provider satisfaction is very important. We need to make sure that we count them as well in the whole healthcare, the whole picture. And when it comes to dollars, it's already, many people have already seen that these dollars are being reported. When a hospital or a doctor charges something, it goes, if there's any Medicare at all in there, it's going to go to the government, and the government has big database engines, and they're starting to put out, if you got a hip replacement at hospital A for $8,000, hey, look, 10 miles away, they're charging $80,000. Why? It goes back to the old charge master idea. So, and not only the reporting of charges, but something called open, I forgot the CMS open, where if there's a relationship, a financial relationship between a doctor and a supplier, it's going to be available to be seen by the public. So I say, yeah, it's worth the work. Get in now.
Because there's really no getting out of it in the long run. It's sort of what you're saying, that it's all of this is converging, and if you don't get in now, it's just going to be harder to get in later.
Mm-hmm. Yeah, and I think the pioneers did a lot of the legwork, and they learned all the hard lessons, and they spent a good deal of the money, and so why not get in there now? And there's vendors springing up now that could help you that weren't there before, that understand the spectrum, the whole continuum of what an accountable care organization needs to worry about. So I think we're at the point now where, it's okay. It's okay to put your toe in the water a little more at this point.
So I'm sure this is something that a lot of folks have thought, that the rules are so complicated, wrapping your brain and your organization around setting up an ACO and getting it to work right is so complicated. Why can't they just, make a contract with the payers and then be done with it?
Mm-hmm. Well, with the upheaval that's going on from the provider side is also going on on the payer side. We're all familiar with the exchanges, the insurance exchanges, not the health, but the insurance exchanges that people, go through and they find, care with at the best price. The bronze, silver, gold plans. The payers, it's in their interest. Again, it's a contractual approach to create as narrow of a network, is what they call it, as possible. Now, is that good? Well, if it's going to attract providers that, feel that they could make more money and give better care, then narrow networks aren't bad. But, there's a lot of people looking at that and saying, is this monopolistic? What's going on here? So the payers are going through big changes. The regulations are changing. patients are moving from, they may sign up for a bronze plan in their state and find out that the doctor that they knew and loved for years is not on that plan and won't treat them anymore. So what's going on with the patient? So I think the answer to this slide is, if you just make a contract with one payer or a couple of them, who knows what the payer's position is going to be in 6 months to a year, how many new payers will be in the field, what's going to happen when the rules change, if they change, and private insurance exchanges occur. What if narrow networks start getting more scrutiny and go away or become regulated? So I think the idea is to just have a good contractual approach to all of the people you do business with.
All right. Well, we have plenty of time for questions, and we do have questions from our audience. If you've been holding your questions, please go ahead and ask them. And again, we'll get to as many as time allows. And then if we don't get to your question, rest assured that our presenter will provide written answers to those if we don't get to those. So here's a question, and I think you've sort of touched on this without necessarily naming it. The question is, are ACOs included in the value-based payment modifier, the VBM as we sometimes call it, which is related to PQRS submission? So how does the VBM take account of ACOs, or does it even?
Mm-hmm. In its own way, it does. If you remember what I said, if you, in the old days, to become a ACO, you had to first be in the shared savings program. There's a lot of things you need to do to say you're in the shared savings program, and then CMS, if you're talking about a CMS ACO, they will then, if you make it, they will grant it to you, and they'll make the announcement. Now, at that point, they'll actually send you, you went in there saying what beneficiaries you have and what measures you want, and CMS will come back and say, okay, unless this has changed recently, because this was the case last year, one of the ways for reporting measures is called the GPRO, G-P-R-O, and there's an ACO GPRO and a non-ACO GPRO. So if you get accepted into the shared savings ACO GPRO, the value-based modifier, you'll have certain measures and certain targets that you'll need to address, and they will be spelled out by CMS to you. So yes, it does apply, but look at your contract with CMS.
Okay, here's a question about GPRO, as you just talked about, and how to report properly. So the question is, my EHR can run the PQRS report, so that in itself is a little unusual these days. But I was obligated, quote unquote, to do the GPRO audit of 200+ charts. I was trained to do PQRS by EHR. Is there a rule that I have to participate with GPRO, or do we have the right to opt out of GPRO audit? Is there a reason why I should do GPRO?
Okay. Well, let me address this, because some of these terms that get mentioned, we have to be clear about them. Now, I think it may have changed this year, but a GPRO last year meant an organization with at least 100 providers in it, and they would go onto a special system, a government system called the IAC system, and they would get approval as a GPRO, and then they report their measures. There's another concept in there called group measures, and many people get GPRO and group measures mixed up. So I don't know if the GPRO limit size has changed this year. So one thing you can do is call the Quality Net Help Desk, and I don't have that 800 number, but if you go to, just Google Quality Net Customer Support, you could get the Quality Net Help Desk and speak to a specialist in the government, or that website I gave earlier, which is www.cms.gov/PQRS. There's a lot of information there, listing of vendors. My vendor, I'm there. You'll see the vendors who could do this, and there'll be, for more information, you'll see more places to read or numbers to call. So I cannot answer that person's question directly because it's it's beyond my expertise, but I could get the answer, or maybe that person can find that with the information I gave.
All right. Here's another question from our audience. Why do you say that PNCH is an ACO?
Well, again, if you look at the idea of a contractual, and that's a very good question. Thank you to the person who asked that. If you go back to my original statement, that think of an ACO as an accountable care organization, think of it as a contract that you're going into as a provider with someone who's going to pay you, a payer. So ACO almost becomes a generic term when you look at it that way. So, but in the early days with CMS, to become an accountable care organization, you had to be part of the shared savings organization. You had to apply as a shared savings and get approved by CMS, and then you got the measures that I talked about. The patient-centered medical home is a little different. The organization that gives certification for that it's not a government organization. It's a public-private, I forgot actually, MQ, the certifiers of patient-centered medical home. If you look at that, you'll see who gives the certifications of that. When you're certified as a patient-centered medical home, it means that there's certain measures that you have achieved and proven that you could do in your population. So, and you could make contractual agreements with other payers. It does not have to be CMS. A patient-centered medical home, if you look at some of the big payers, you'll see, it's like Optum and Aetna and Blue Cross Blue Shield, you'll see that they're in these arrangements. So generically, an ACO being a contractual agreement to deliver care and work with a payer of that care, a patient-centered medical home falls very clearly in that generic high-level concept. But now, of course, if you're talking about a CMS ACO and the shared savings program, that is very specific. That wouldn't be a patient-centered medical home 100%. You'd have to have a certain number of beneficiaries. You have to have a primary care gatekeeper in there, or primary care has to be part of that. A primary care provider or providers who are part of a shared savings CMS ACO cannot belong to more than one, whereas a specialist can belong to more than one, which introduces the whole idea is if the government is paying you for saving on care, and a provider is in more than one, are they double paying? Are the payers paying for the same savings? The CMS shared savings ACO is very specific about what they mean an ACO is. But they also, you could look at the CMS website and you see that they talk about it and say, this is really a high-level, conceptual, and this is the way we're going to do it.
So why do you say that everything is moving toward pay for quality? This is another question. I think we have time for one more. And even toward ACOs, just to riff on what the audience member was saying, if you think about ICD-10 and how Congress kind of stepped in under pressure from doctors, among others, to kind of delay that, isn't there also a lot of pushback on pay for quality?
I haven't really seen a lot of pushback on pay for quality. If you go back to the old program that PQRS became, which was originally called PQRI, or Pay for Performance, P4P, there was a lot of work that doctors put into and got a very small amount of payback for that work. And a lot of them just said, I'm not putting any more work into this. I'll just take the hit. I'll take the 1% reduction, or I'll find other ways to make up my revenue, but I'm not going to bother with, a doctor's time is unbelievably, it's expensive, and they have to use whatever time they can to give the best care they can. Now, if they're going to sit around, they're already working, 23 hours a day. So if they're going to sit around and try to figure out how to do all the right measures and type them into a screen to get back 1% of their revenue, they're not going to do that. But now that pot's getting bigger, right? The CMS revenue as a whole is getting smaller, but the movement toward where the higher payments are within that smaller pot. I'm sorry, I just heard something on the line. Is that, we're still on?
Yeah, I don't know where, yeah, we're still on. I'm not sure where that's coming from.
Okay. So I'm not seeing the provider, you're not going to, I haven't anyway, seen a provider that says we don't want to do quality care. However, I think if maybe the speaker or the questioner really was saying, you know, is this really pay for performance or is this the old PQRI? Why should I bother with it? I think, you know, expanding the definition of reporting quality as the triple aim is trying to do with CMS and the payers are following, then there's no way to not do it, in my opinion, and stay in business, unless you're going to be a pure concierge doctor or provider and just take, you know, straight payment directly from the patient and not worry about anybody else funding you.
Right, and we've certainly heard stories of folks going that route, but obviously there's not a lot of opportunity in that direction. I mean, only so many people can become concierge. It's not going to replace the system, to say the least. So
yeah, well don't forget, the recession has hit everybody, not just providers, but patients and as well. The recession has hurt everybody's pocketbook. So how many people can still afford, you know, some of the original concierge fees were quite high per year. Now they're moving down and they're more reasonable, but they're not really concierge doctors. They're more in agreement with, you know, radiology providers and groups. So it's actually, if you think about it, they would probably kill me for this, is but they are doing an ACO model, but they're just calling it what they call it.
Well, I certainly agree with you that everything is moving in this direction, and you know, you just see it in all of the CMS initiatives. They're really trying to bring all these programs together, and there's such a push toward this move toward quality, both measurement and then pay for quality. Really,
Yep.
I think you're right that there's no turning away from this at this point.
Well, thank you.
Well, go ahead.
No, I was going to say, this is what I see. The Suncoast Rio, you know, we do business primarily. We started in Florida in the Southwest region, and we also do work, and now we have, you know, people calling us from Honolulu, from New York City. We have a sister organization up there. We have an ROI partner in Cincinnati. We do work in Virginia. We do work. We have some clients in California. So I'm every day talking with the people who are interested in this kind of thing, and I'm just seeing it going in that direction. My phone is ringing, and my email is overflowing.
Well, along those lines, if folks are interested in the services that Suncoast Rio can provide, you can see the URL there on your screen. Go to www.suncoastrio.com to learn more, or that actually should be org, I'm sorry.
Well, actually, it's both. You know, there's a funny, I'm not going to tell a long story here, we're at the end of the group, but we originally started as a membership, and we were a .org, and when we decided 2.5 years ago to be a commercial enterprise, we changed our IRS, well, not our IRS, we changed our state designation, because we've always been a corporation. We were never a nonprofit. But we changed our designation to be clear that we were a commercial vendor, and so we have both .com and .org. Both will work.
Well, that makes sense, because I thought I'd actually hopped on over to your site to make sure that that was right, and it's good to know that both will work. So, you know, whether you're looking for a PQRS registry or help with ACO questions, any of these quality reporting issues is something that Suncoast Rio would be happy to help you with. So do go to their website and learn more about the services that they offer. Remember that we're going to send an email follow-up that will include the slides from this session along with the video recording. I believe that Lou's also going to provide a white paper on some simple steps on how you can build an ACO or how to build an e-clinic. So I know everyone will look forward to that. Keep your eyes peeled for that follow-up email, which you should get here before the end of the week, certainly. If you need training in meaningful use, PQRS, or HIPAA compliance, visit www.formedtraining.com to access our self-paced online courses. If you prefer instructor-led workshops, you can visit www.formedworkshops.com. You can visit formedapproved.com to learn more about our upcoming learning lunches. There's a learning lunch button there. The same lunch box that you see there on your screen will take you to a listing of our upcoming events where you can learn more and register. Our next learning lunch will air September 23rd and has the title, How Do Docs Really Feel About HIT in 2015? So I want to thank you again, Lou, for joining us today and sharing your expertise. It was a very informative session.
Well, thank you for the opportunity, and thank you to everybody who joined in to listen.
All right, folks, we'll keep an eye on your email box on our homepage for other upcoming topics, and thank you again for joining us today.